Begin with the program, I would request Dr. Prayas Sethi to give us a holistic on how diabetes can affect the systemic, can involve all the systems of the body.
Thank you, ma'am. Thank you. I would like to thank all of you, the Ophthalmological Society, for this wonderful opportunity. And ma'am, I would like to share my screen.
Yes, please, Prayas.
So I think I'm audible and my screen is visible.
Yeah, perfect.
Okay, so I would like to start with some of the basics, the most important of which is how to diagnose a patient of a diabetes. So HbA1c is the classical test more than 6.5%, or fasting blood sugar of fasting of 8 hours of more than 126 milligram per deciliters, or an RBS, random blood sugar of more than 200 milligrams per deciliter with signs and symptoms, or a 2-hour postprandial glucose of more than 200 milligram per deciliter during an oral glucose tolerance test. So any of the following, if present, we should be considering or diagnosing the patient as diabetes and starting the workup. So we clearly know the types of diabetes, type 1 being the immune mediated, the deficiency of insulin related diabetes mellitus. Type 2 is the classical most common type of diabetes, which is because of the insulin resistance or secretory defects. The other types are type 3 and type 4. Type 3 is the specific types of diabetes like monogenic forms, neonatal diabetes, exocrine diabetes, genetic insulin defects, endocrinopathies. And type 4 is the gestational diabetes mellitus. So multiple pathophysiologies contribute to the diabetes conundrum, and it ranges from defect in the insulin secretion, the incretin effect, obesity related lipolysis, uh, liver related increased glucose production, even brain neurotransmitter dysfunction, decreased glucose uptake in the organs like skeletal muscles, increased glucose reabsorption. So various mechanisms contribute to the pathophysiology of diabetes. So talking about the complications and how does it affect the body, is the most important are the concern in the emergency are the acute complications, which include diabetic ketoacidosis, hyperosmolar non-ketotic coma, and hypoglycemia. Another other important ones are the acute infections that can happen in patients who have poorly controlled diabetes, and the perioperative complications that can happen if the diabetes is not controlled during the operative period. Preoperative, perioperative, postoperative period are important periods when complications in can happen. So this is poor diabetes control can lead to all these. What are the chronic complications of diabetes? So microvascular, we all know nephropathy, neuropathy, retinopathy. Macrovascular, cardiovascular, cerebrovascular, and peripheral vascular disease are the most common. So, and it also is well known that it is the duration of diabetes which is the most important factor that leads to these chronic complications. So the longer the duration of the diabetes, longer is the chance of setting in of chronic complications. Yes, blood sugar control is important, but duration is considered to be a more important factor than the blood sugar control. So both the factors are important, the blood sugar control and the duration of the disease. The basic pathogenesis resolves around the inflammation, endothelial dysfunction, advanced glycation end products, vascular effects, circulating free fatty acids, and a prothrombotic state that is created. Now, the effect is not just limited to the systems that we just talked about. It affects almost every organ of the body. The most common and most identified of these being eye, skin, infections, and musculoskeletal complications. So once we once we have this understanding of the affected organs, what is our target? The target before any, uh, we have to decide the target of HbA1c, fasting blood sugar, and postprandial blood sugar. So HbA1c target less than 6.5% is the recommended target in a stable diabetic population. However, this may vary. Fasting blood sugar 70 to 130 milligram per deciliter, and postprandial blood sugar should always be less than 180. So now this slide shows why and in what conditions HbA1c should be more stringent and in what conditions HbA1c should be less stringent. This is important for all of us to know that all patients cannot have one. This is a tailor-made HbA1c that is required. For example, patients who have risk of hypoglycemia, who have uh, longer disease duration, who have lesser life expectancy, who have severe comorbidities, who have established vascular complications, who cannot give much time to their treatment, who don't have that attitude of well controlled sugar, who do not have the resources and support system, these people need to have less stringent targets as compared to those who are on this side of the normogram. So starting with the treatment, lifestyle modifications are the most mainstay of treatment in the beginning, though it cannot alone serve the purpose most of the time. So patients now, some of the patients have this understanding that now I'll do exercise for 1 month and I'll control my diabetes. That is fine, but with that the work doesn't end. It has to be supplemented with further continued lifestyle modifications and medications. So some of the common drugs used are metformin, SGLT2 inhibitors, GLP-1 receptor agonists, DPP-4 inhibitors, thiazolidinediones, sulfonylureas, and insulin. So talking of the important guideline, the most important thing for us to know is the first drug is always metformin. So metformin along with the lifestyle management should be the first line of management. After that, we get an idea from the patient's history whether he has increased risk of atherosclerotic cardiovascular disease or kidney disease. If it is so, then GLP-1 receptor agonists and SGLT2 inhibitors have higher benefit. If the patient has features of heart failure, SGLT2 inhibitors have higher benefits. If patients, if there is compelling need to minimize hypoglycemia, then insulins and sulfonylureas have to be avoided, which are glimepiride and netiglinide, repaglinide. If there is compelling need to reduce weight gain, then we should be using GLP-1 receptor agonist and SGLT2 inhibitors. When cost is a major issue, sulfonylureas and thiazolidinediones become the second choice. So overall, based on this, I would just summarize that metformin and lifestyle modifications are the first line of therapy. Second line of therapy is decided based on the patient's risks: heart disease risk, hypoglycemia risk, weight gain risk, or cost. These factors actually decide what is the second drug. When should be using insulin? Insulin is used when HbA1c is not achieved by at least 3 oral hypoglycemic agents in maximally effective doses, or HbA1c is more than 9% at presentation and there is a risk of glucotoxicity. So acute glucotoxicity can lead to reduced insulin secretion. So that has to be controlled in the acute setting. In the inpatient setting, like in critically ill patients, also we need to use insulin. And when there are contraindications to oral hypoglycemic agents like kidney disease. Apart from this, as we have already said, all patients with diabetes should be having a significant counseling regarding weight reduction, because glycemic control prevents nephropathy, neuropathy, retinopathy, but weight reduction reduces risks of diabetes, hypertension, dyslipidemia, cardiovascular disease, kidney disease, fatty liver disease, reflux, sexual dysfunction, incontinence, sleep apnea, reflux, and musculoskeletal pains. And another important thing I would like to highlight is that all patients should be screened for microvascular complications at presentation, whatever is the presentation, at whatever time is the presentation, whether it is younger patient, older patient, symptomatic for that organ or not, all patients should be screened for retinopathy and nephropathy and neuropathy by a comprehensive examination. Retinopathy should be evaluated by ophthalmologists. Neuropathy has to be evaluated by specific neurological tests, especially monofilament test in the early stages. And nephropathy has to be screened based on urinary albumin creatinine ratio and then further referral to a nephrologist. Inpatient glycemic management is a specific area where the most important thing to know is that blood sugar target is between 140 to 180 in critically ill patients, and in non-critically ill patients the target is less than 140 milligram per deciliter, and less than 100 milligram per deciliter should never be there in hospital setting, because there is a risk of hypoglycemia. In the surgical settings, pre-operative period, we need to be careful that blood sugar is well controlled before the patient undergoes for surgery. 140 to 180 is the target again for the pre-operative, intraoperative, and post-operative period. We do not recommend a stringent control of blood sugar, because the excess use of insulin and the recovery period may be accompanied with hypoglycemic episodes. So blood sugar of 140 to 180 is the recommended target blood sugar in perioperative period. Just a word about insulins. It's important to know that insulins are regular as well as analog insulin. In analog insulins, our amino acid sequence is genetically modified, and in regular insulin, it's same amino acid sequence as the human. So basically, they are short acting, rapidly acting. Short acting one analog insulin are lispro, aspart, glolicine, and long acting ones are glargine, detamir, and diglodec. Similarly, in regular insulins, short acting is regular insulin and intermediate acting is NPH insulin. We also have pre-mixed insulins like NPH and regular combination and lispro and lisproprotamine combinations. But there are some complications that are associated with insulin therapy, and these include hypoglycemia and hypokalemia, and all patients should be monitored for this in hospital setting, and for hypoglycemia in the outpatient setting. Thank you. This is all for my talk. I would like to have any questions if anybody wants to.